As providers across Maryland continue to respond to medetomidine, Max is sharing the following example to illustrate how these cases could present in practice.
Hello, I'm Jordan Nahas-Vigon, an internist at Johns Hopkins Bayview Medical Center and Johns Hopkins Hospital. Over the last few years, I've treated a number of patients with medetomidine intoxication and withdrawal. I'd like to walk you through a recent case. Recently, an otherwise healthy patient came into the hospital with a heart rate of 36, hypotension, and somnolence, characteristics of medetomidine use on top of fentanyl use. His respiratory rate was adequate, so naloxone wasn't needed. But remember, if there is respiratory depression, give naloxone. He had used fentanyl daily, and he also had access to test strips, so he knew that medetomidine was in the drugs as well. 4 hours later, his vitals normalized, and we immediately started full agonist opioids, clonidine pills and patch, and antiemetics. And we got the conversation going early regarding medication for opioid use disorder. He had a preference for methadone, so we started that right away. Despite treatment with opioids, clonidine, and antiemetics, the patient's heart rate and blood pressure continued to rise. Once patients develop significant nausea and vomiting, they typically need to be transferred to the ICU for dexmedetomidine infusions, as they can no longer tolerate oral medications. The patient developed a typical constellation of medetomidine withdrawal symptoms: tachycardia with a heart rate of 120, hypertension with systolic blood pressures in the 180s and 200s, constant nausea and vomiting, rigors, diaphoresis, and delirium. In the ICU, his labs were also typical for this stage of medetomidine withdrawal. He had a lactic acidosis, hypokalemia, and a white blood cell count of 20,000. We started IV dexmedetomidine alongside IV opioids and antiemetics. Shortly after starting the dexmedetomidine, his blood pressure and heart rate improved. After about 12 hours with up titration of medications, the vomiting improved as well. It's important to watch for QTc prolongation, especially with this many medications on board. This patient remained on the dexmedetomidine for about 36 hours before his symptoms improved enough to start to wean the infusion off. We can wean dexmedetomidine by cross-titrating with clonidine. And since he still had his clonidine patch on from admission, this facilitated weaning off the dexmedetomidine. It's worth noting that some patients continue to have severe hemodynamic instability, vomiting, and agitation, even on the dexmedetomidine. For these refractory cases, we may need to use additional agents, such as low-dose ketamine or propofol. It's also important to assess for alcohol and benzodiazepine withdrawal, as the hypertension, tachycardia, and rigors can look very similar. I try to assess for this risk when I first meet the patient before they go into withdrawal. If withdrawal is difficult to manage and we cannot rule out alcohol or benzodiazepine involvement, we may add a phenobarbital taper as well. The remainder of this patient's course was uneventful. He received IV fluids and electrolyte repletion. His labs normalized, and once he was tolerating oral medication and food, he was transferred back to the floor. We titrated him to 110 milligrams of methadone, which he felt was an appropriate dose to control his opioid cravings. We coordinated a referral to a methadone clinic near his home, and he was discharged with a 1-week clonidine prescription and a prescription for naloxone. Patients who are discharged on clonidine should be seen for follow-up within a week of hospital discharge. Cases like this underscore the need for clinical vigilance as the illicit drug supply continues to evolve. For real-time clinical consultation, reach the MAX Warm Line by calling 1-855-337-MAX. You can also connect with Max via email at max@som.umaryland.edu or by visiting marylandmax.org. Thank you for your hard work caring for all Marylanders.